also check your presentation prior to.
He already checked
Yes,
it, sir.
checked. He has
He
checked.
already checked it, sir. Yes, sir. Everyone, we are live on YouTube.
Welcome all.
Welcome to the
Yes, Naresh, please.
Yes, sir. Welcome to the Indian Arthroscopy Society webinar series for IAS Defense Wing. Today we have with us eminent personalities and IAS secretaries are with us, Dr. Rajiv Raman sir, and from the Defense Wing, Senior Army Personnel, Dr. Chetan Sood sir, and Manish Sood sir, along with the IAS Defense Wing convener, Rupesh Prasad sir with us. I would like to hand over this meeting to Dr. Rajiv Raman sir to introduce the faculties and start the meeting, sir.
Thank you, Naresh, and wish you all a happy Republic Day. And thank you, IES Defense Wing, for organizing this wonderful webinar on the 26th of January. And I would like to especially thank Dr. Rupesh because he thought of this theme, the soldier athlete. And thanks to all the faculty, Dr. Shunis, Dr. Pankaj Rai, Dr. Hishikesh, and, Colonel Rupesh, and Dr. Arvind. A special thanks to Dr. Chetan Sood and Dr. Munish Sood, who are also moderator for this session. Now I would like to hand over to the convener, Dr. Naresh Gaud, Dr. Rupesh, and Dr. Neha. Please go ahead.
Rupesh,
Thank you,
sir.
sir, for your kind words. And soldiers are unique cohort because of their high demand professional commitment. And the soldiers, they are soldiers as well as athlete at the same times. So that's why we thought of this theme for the webinar. And we as a arthroscopy surgeons have the responsibility to understand their problems and address them so that they can live a life of a dignified soldier. So today we have within us the two eminent orthopedic stalwarts, Chetan Sood sir and Munish Sood sir, who are the pillar behind the defense wing in the Indian Arthroscopy Society, which was introduced in 2022 at ISCON Coimbatore, and I was also part of that. So I feel privileged, and we have them as a moderator today. So, and this is the first defense wing webinar. So I would request Chetan sir and Munish Sood sir to take over the proceedings and start with the moderating the session, sir.
Thank
Over
you,
to you,
Rupesh.
sir.
As you already brought out, this alignment took place about 4 years back. We were aligned with so many other societies, but IAS was not something part of it, and it was my dream, and it is now I can see that. So this year, this is the first one, but last year also we had one such similar one. And so the aim, I just want to give a perspective that jointly there are about 30 centers in the armed forces, all the three forces, where scopy is being done. And close to just short of 10,000 scopies are done. Bulk are knee and hip, knee and the shoulder, of course, but also small joint. Most of the larger centers now have the small joint scopies also, and some places the hip also has started. And a young generation of scopy surgeons are now in the way who are specialized trained for scopy. And a scopy center is now coming up in Army Hospital RR also, which is a flagship hospital of the armed forces. With this, the purpose of the seminar is to, of course, bring out the work that we do, which is different from or not usually seen in the other similar centers, which are of great excellence in the country. And with that perspective, especially topics which are very unique to the armed forces are selected for the presentation. With this, I will request Manish, if you can call the next first speaker. Manish, you want to?
Thank you, sir. As rightly pointed out by Chetan sir, that knee and shoulder are kind of a main bulk of our surgeries, and ACL injuries, we all know that they are the amongst the most common and career impacting musculoskeletal injuries as far as armed forces is concerned. And understanding their demographic profile, identifying their risk factors, and which can guide us in making preventive strategy. Dr. Shunish is going to talk about the demographic profile of ACL injuries, in armed forces. Dr. Sunish, please.
Thank you, sir. Good evening to all seniors and colleagues. Happy Republic Day to all. I am Sergeant Commander Sunish, and I'll be talking on demographics of ACL injuries and armed forces. As we know, anterior cruciate ligament injuries are commonly seen in athletes and high-demand professionals. ACL deficiency leads to instability of the knee joint, which can be a career-ending event for the high-demand professional. In the military population, it can be the cause for rejection or invalidment after going through the stress and strains of difficult training. The risk factors are divided into either non-modifiable or modifiable risk factors. Non-modifiable includes female gender, genetic factors, anatomical factors like the slope of tibia and hyperlaxity of joints, hormonal factors, neurocognitive functions, slower reaction and processing speed can cause it, previous injury to the knee. The modifiable risk factors are weather conditions, level and type of activity, type of playing surface or footwear, and type of equipment used. The understanding of these risk factors can help trainee and training staff in the prevention of these injuries. Parachuting and airborne operations, combat training and simulations, sports and physical training, obstacle training, military gear such as heavy backpacks or body armor are common causes of ACL injury in armed forces. These are the few common causes of ACL injuries. Armed forces personnel are to be considered like elite athletes in terms of fitness required, in addition to performing combat exercises that define military practice. Large number of ACL injury means loss of trained military forces and the skills in warfare. So ACL injury can lead to post-traumatic knee osteoarthritis at a very young age. The physical and economic burden to the society increases, and in military service, ACL injury can lead to termination of a perfect military performance, which further leads to early retirement also. The military personnel has to perform extremely rigorous physical activities and demanding missions on land, air, and sea. So there is an apparent lack of reports specifically focusing on the ACL injuries in the military environment. So we studied the pattern and profile of ACL injuries recorded in serving soldiers. Ours was an observational study over a period of 4 years at one of the tertiary care military hospitals. The inclusion criteria, all serving soldiers presenting with an ACL tear and willing to participate in the study were taken. The exclusion criteria included any knee pathology or re-injury to already reconstructed ACL. The sample size was estimated based upon the total garrison strength. The sample size required to perform this study was approximately 385 subjects, which were calculated at 95% confidence level, and the margin of error was taken as 5%. So we got 524 serving soldiers with ACL injuries who were studied. 34 patients were excluded as they were not fulfilling the inclusion criteria. The average age was 29.6 years, and 520 patients were male and 4 were female. The left knee was involved in 283 patients, while the right knee was involved in 241 patients. These are the mode of injury in patients. We can see military activities and sports-related activities leading to ACL tears. So the mode of injury in sporting activities was seen to be maximum 46.6%, followed by military training related activities 34.3%. And injuries associated with ACL tear were medial meniscus tear and lateral meniscus tear, which were found to be more, and then followed by osteochondral injuries. Isolated ACL injuries were the most common injuries seen, which was 235, and medial meniscus along with ACL was seen in 149, whereas lateral meniscus was seen in 115 patients. Collateral ligament injuries and PCL injuries were less. There were a good number of osteochondral injuries, 67. And we saw that the lateral meniscus injury associated with ACL tear was significantly higher in patients in training-related injuries. Now, the ACL injury can be a career-ending injury in athletes And in military personnel, it causes invalidation from military. So, with the advent of newer surgical skills and rehabilitation strategy, the return to activity is possible for them at a short-term follow-up. The rate of re-injuries and premature retirement is still higher in patients with ACL injury than healthy individuals. In armed forces, these injuries become an economical burden to the person as well as to the state. ACL injuries are much more prevalent in military personnel as compared to general population, and the environmental factors such as strenuous physical training, repeated stress activities, and sports-related activities seen in military personnel are the major contributing factors to ACL injuries. Now, this is a 9-feet ditch activity. The prevalence of landing-related injuries were the most common in this, approximately 20.8% of all patients. The landing activity is a part of the training in which the individual has to jump over the ditch onto an uneven surface on sand or sandbag at the end of the ditch. The landing is commonly done on one leg with hip and knee in extension, which leads to adduction and internal rotation at the hip and abduction and external rotation at the knee. These activities are generally performed either at the beginning of the training or after the end of 5-kilometer run. So various studies support complex multiplanar loading of the knee, that is loading in the sagittal transverse and frontal plane, as the cause of non-contact injuries. So the explanation for the higher number of landing injuries in training could be sudden deceleration at the time of landing with the knee close to extension or slightly bent. The first two images here shows the incorrect way of landing. On one leg, if you are single leg landing, in slight flexion of the hip and knee causes valgus at the knee and stress to the anterior cruciate ligament. When both legs are used in landing and are in slight flexion, internal rotation and adduction of hip with knee inflection, internal rotation and abduction leads to anterior cruciate ligament stress. The third and the fourth images are the correct posture of landing with hip inflection, external rotation and abduction, and knee inflection, shoulder width apart, facing forwards. So various studies have reported the type of surface as an environmental factor contributing to ACL injuries. Soft and flat landing surfaces can be used as an alternative to prevent landing-related ACL injuries. ACL injuries are more common if performed without warm-up or in a fatigue state, that is towards the end of the training session. And landing activities should be performed at the start of the training session after proper warm-up specific to landing activities. In conclusion, ACL tear and associated injuries are one of the most common in the Indian Armed Forces. Non-contact injuries are relatively more common. Proper training and education on landing techniques and knee care is essential in reducing the ACL injuries. Regular exercise program to improve knee strength and flexibility is required. Gradual progression in training intensity and duration should be done. The strategies such as soft and flat landing surface, proper warm-up, and tailored training programs should be introduced. These are my references. Thank you.
Thank you, Sunish. I think we all as military surgeons know that the 9-foot ditch, which is an essential test the soldier has to pass at the time of induction from the very first, even before induction, even if before selection, he has to pass this test. I went for the SSB, I failed in that, of course, but you have to do this test. So I think two things you brought out very quickly. I'll just summarize that. That one is that the ACL injury is such a thing that that's as of now in the military, it's almost like a career defining injury. And so many of our soldiers, I'll commit here, is that they do not seek treatment within the military setup, they go outside, and the prime reason for that is not because they are not getting at the surgery in optimum or good shape, is because they're scared of losing their medical status, in which it'll take about 2 years for them to go back to their status or never go back. This is the main reason that they do that. So I think you brought up 2-3 points, which I'm very happy about, is that firstly about the demography. It is a very young, economically very and crucial people. And as you know, in the military, you cannot have a unfit. They're all elite athlete status. If you have one unfit guy in a unit, 2 others are engaged to take care of him in an operational situation. So that's a big degradation of manpower during operational work. So that's the biggest thing which works on the commander's mind. So that's why we are supposed to get them in shape, and that's why ACL injuries, we are very reluctant to upgrade them to shape 1 state. Okay. Not that if they are even, so many of them go to big hospitals and get a status that he's very good, but he's not militarily well for that because even if he becomes a possible liability during operations, then it's a big drag on the unit's strength. That's the reason we are a little strict with them. And if you brought out the thing, so I think your recommendations are well taken. Uh, don't you think we should take out this 9-foot ditch out of the training program if it is 20%, and rest is sports. Of course, sports is something that happens everywhere, but this one particular thing.
Sir,
Sir.
in military hospital Jodhpur, we also conducted that same kind of survey, and we found that it was 30%. A 9-foot disc was culprit for 30% of our patients with ACL injuries.
Yeah.
So the number might vary from 15 to 30%. So it is definitely there, and it is very significant, sir.
So I'll just give you one good news on
Sure.
it. That is, the military has already taken the action on it. This 9-foot ditch for the audiences, it is with the full backpack. It was with all the load. So the person
Yes,
had
sir.
around 20 kgs backpack and a rifle on with him when he was doing it. So now they've taken out the load out of it. So you can do it without the arm and backpack, right? That is one thing that they have done. So without that thing, I think it will reduce the incidence a little bit less.
Yeah.
But the military
Yes, sir.
commanders want that this should be there. Okay, right. So any questions, Neha, from the audience or anybody from the panel? I think that kind of covers the thing. So we can move on to the next talk, which is
Uh,
Manish.
So we've already talked about the demographic profile. So next is the technical aspect of ACL. So we all know that a successful ACL reconstruction depends upon so many technical factors, like successful ACL reconstruction depends heavily on precise femoral placement, tunnel placement. Even a small deviation can affect graft function, and the long-term outcome may vary. So Dr. Pankaj, he has done a kind of a RCT where he's compared various kinds of tunnel placement techniques. So he's going to talk about the various tunnel and which one is better. We're going to talk about femoral treatment, tunnel accuracy, and are we hitting the mark. Dr. Pankaj, please.
Thank you, sir. Good evening, everyone, and happy Republic Day. Today I'll be talking on a very pertinent study, which randomized study which we have done, which is basically the accuracy of the femoral tunnel placement in all inside ACL reconstruction to address the sole question: are we hitting the mark? That means, are we hitting the bullseye, the point where we have to place our femoral tunnel? So this study was conducted at a Air Force hospital in Jorat, which is located in the remote northeast area of our country, providing medical cover to the guardians of our frontier. A lot of young active military soldiers are deployed in these areas. At the outset, I have no disclosures to make, no financial, no conflict of interest, no financial disclosures. ACL injuries, we all know that they are very common in athletes and more so in military personnel, because as we said that military personnel are more or less a soldier athlete. They have to undergo so many training activities and operational activities in their day-to-day life that they are always prone to such kinds of injuries. The global incidence is approximately 68.6 per 1 lakh person per year. In Indian Armed Forces, almost 1/4 of all the knee injuries which are reporting to our service hospitals have some amount of the ACL injuries. And these ACL injuries are one of the most common cause of prolonged morbidity in our soldiers, as rightly brought out by my previous speaker. So the combination of the high incidence and the pressure of returning back to the operational activities make it more important that we should treat these injuries in a very precise manner. So we all know that for the ACL injuries, ACL reconstruction is the gold standard treatment. All insert technique is a lesser invasive modern approach. And we all know that correct tunnel placement is very crucial for the survivability of our reconstructed ACL and the longevity and the functional outcome. So femoral tunnel, we all know that that an ideal femoral tunnel should be centered within native ACL footprint. It should be low in the notch, about 20 to 25% from the posterior edge. It on the basis of the clock, it should be around at 10 o'clock position to the on the right knee and 2 o'clock position on the left knee. The clasp should be horizontal in orientation, and the tunnel length should be minimum of 25 millimeter or more. So how to hit this bullseye, and what is this bullseye all about? So we know that once we see the cross section of our lateral femoral condyle, the medial wall, we have a ridge which is called a lateral intercondylar ridge or the resident ridge, and there is a perpendicular sort of very thin ridge perpendicular to this, which is called as bifurcate ridge. So whenever we are aiming for the ACL, we always aim that our tunnel should be posterior to this lateral intercondylar, posterior to this bifurcate ridge and behind the lateral intercondylar ridge. So this is the cross section, how it looks once we see it on the arthroscopy, and once we see on an X-ray, it should be almost 30 to 35% below the Blumenstadt line or the intercondylar line or the roof, and it should be around about 20% or 25% from the posterior edge of the lateral femoral condyle. So this is the aim which we all have once we are doing the ACL reconstruction. So femoral tunnel placement is the key, as I already told. There is this article by Herman which was published in 2020, and it says that poor tunnel position leads to up to 50% failure of the ACL, and anatomical tunnel placement of the ACL results in better rotational stability as well as lower re-tear risk. And this review article, which was by Sametier and was published in Journal of Bone and Joint Surgery in 2015, they have found out that trauma is the single leading cause of the ACL reconstruction failure, followed by the technical errors. And among the technical errors, this is the malplacement or the malposition of the femoral tunnel, which is the leading cause. So the femoral tunnel placement is one of the important cause of the failure of the ACL following the re-injury. So, but there is a gap in the literature. All the existing studies, they are either where they have compared the two techniques of the ACL reconstruction are either a cadaveric study or a retrospective CT analysis. They are non-randomized. They have small sample cohorts, and there are only very few randomized trials. There's one trial which was done by Gang and Gay in 2018, which compared AMP or the intromedial portal with the transtibial portal, and the other by the Song et al., where they have compared the outside in drilling technique with the intromedial portal. There is no high quality RCT assessing the accuracy of three techniques together. So our aim in this, so the aim of our study was to determine which of the three techniques result in the most anatomically placed femoral tunnel in terms of the position as well as the length of the tunnel. So we compared the three techniques: intromedial or the AMP, far intromedial portal technique or the FAMP, on the outside in drilling technique or the OI. And we hypothesized that one of the specific techniques will demonstrate superior accuracy in femoral tunnel placement as compared to the others. Our study design was a prospective randomized control trial. We have total 150 patients enrolled in our study. Inclusion criteria was clinically and radiologically evidenced ACL injury, symptomatic knee instability, consenting to undergo the ACL reconstruction and postoperative CT. Exclusion criteria was the previous ACLR requiring revision surgery, case of multiligamentous injury, and only for the follow-up. Randomization was done by using a computer-generated block randomization number implemented by the study nurse. We had three groups of 50 each. Group 1 like AMP, FAMP, and OI. So surgical procedures was conducted by a team of 2 surgeons, and both of them follow and a standardized protocols was followed for each and every patient right from the time of the preparation till the time of the rehab. Assessment was done. Postoperative assessment was done by using CT scans to assess the femoral tunnel position and the length. Entry position was done by Brandon Herter quadrant method. 3-dimensional tunnel axis was done by Bezdesky's method, and tunnel length was measured on the axial CT images. The radiologist was the assessor, and he was blinded, and there was no and radiologist has no access to the operative details. So the evaluation was independent to avoid the bias. Placement of the tunnel was assessed by using a Magnuson criteria, wherein the tunnels were graded as good, fair, or poor based upon their relation to the bifurcatories, either anterior or posterior. Evaluation of femoral tunnel socket position was done by using Brands and Hertel quadrant method. The center of the socket was measured vertically. It was measured. The distance was measured from the roof of the intercondylar notch to the center of the tunnel, and the horizontally the distance from the posterior edge of the femoral condyle to the center of the tunnel. The socket angles were also measured on the CT films in axial, coronal, as well as the sagittal view. So primary outcome in our study, the primary outcome was the femoral tunnel placement, which was categorized as good, fair, or poor. And since it represents the ordered nominal data, so it was compared using chi-square test. And since we have compared out AMP, FAMP, and OI technique in multiple paired tests, so the significance level was set as 0.25 by applying Bonferroni's correction. Tunnel length was measured across all the three groups using unpaired student test, and the secondary outcomes like tunnel orifice placement ratios, tunnel access was a continuous data, and they were measured by using mean, median, and standard deviation. Coming to the results, all the groups were comparable in terms of demographics, so as to have a clear-cut accuracy of the so as to derive a clear-cut accuracy about of all the three techniques. Among the three techniques, majority of the cases which we had in our studies were having sports or the training-related injuries, followed by the road traffic accidents. They were all the males. In the study, and there was no females in the studies. Based upon in our results, almost all the three techniques have satisfactory placement of femoral tunnels. Almost all the three techniques achieve more than 80% satisfactory placement of the tunnels. However, optimum placement was higher in OI and FAMP as compared to the AMP, and it was statistically significant. The length of the tunnel was maximum in case of the OI, followed by the AMP, and FAMP had the shortest tunnel, and it has so that's why we can say that it has a maximum chance of blowout, and OI reduces the risk of the blowout. The socket angles, when we compare the socket angles, we have found out that OI has a flatter and better oriented tunnels as compared to the AMP and FAMP. Complications were in AMP group. There were 2 cases of fixation loss and 1 posterior blowout. In FAMP, there were 1 posterior blowout and one button sitting on the IT band. In OI, there were no significant complications. When we searched the literature, we have found out that in literature there were very few studies that, as I've already told, which have compared either AMP with transtibial or AMP with OI or AMP with OI. And these studies have found out that OI tunnels were longer, with better aperture shape and less acute graft bending. So in discussion, we can say that AMP is the widely used technique, but it has limitations. It has better tunnel entry point. Better tunnel entry point was provided by OI and FAMP, but however FAMP produces shorter tunnels, which has the risk of blowout. Socket orientation is better in OI. OI resulted in flatter, more posterior tunnels and with better accuracy and length orientation. The strength of this study was that it was the first study comparing 3 contemporary femoral tunnel preparation techniques in ACLR. It was a single center study which ensured the surgical equipoise and true randomization. Blinded outcomes were assessed by trained radiologists evaluating the tunnel placement. Limitations was that it did not assess the functional outcomes written to the sport or the graft failure rate, which can correlate with the anatomy. It focus was limited to the anatomical tunnel placement and not the clinical impact. And being a single center study, it limits the generalizability across the multiple surgeons or the centers. So to conclude, all the techniques have achieved the acceptable femoral fixation, femoral tunnel placement. However, OI produces a better tunnel placement with a longer tunnel and better oriented tunnel. But whether these anatomical accuracy will corroborate with the clinical in terms of the clinic in clinical terms, in terms of the functional outcome and the survival of the graft is still it still need to be assessed by further studies. So take home message is correct femoral tunnel placement is critical for the ACL success. Outside in drilling offers optimal accuracy and safety. Incorporating OA may reduce the risk of failure in the ACL. Thank you.
Thank you, Pankaj. Are there any questions, Neha? No, there are no questions. I think, Pankaj, there are three aspects to a failure of ACL, and ACL failure is a very distressing thing because you do everything almost the same way all the time, and somehow some of them fail. So most of the common causes are mechanical or biological, and of course, a good rehab. And I would also say the next speaker here is Rishikesh Pandey, and they have brought out a great rehab protocol, which includes the prehab part also. And for the information of the audience, a good protocol which a lot in the army have started doing now is helping us getting them back to their active life.
Yes.
Going back to the pre-injury status now, very good. So I mean but it takes a lot of time and effort. That's one thing which Rishikesh has been doing there. So I think the correct placement of portals and the tunnels is very crucial, and you brought out the aspects of it, highlighting the importance. There can be nothing more said about that. You have to do it. Dr. Raman, anything you'd like to add?
There is one question for Dr. Pankaj. There
Yes.
is a general consensus from in vitro and vivo studies that the ideal position of the femoral tunnel is when the ACL graft is isometric. So I think he is asking about the direct fiber. So what is your say on this? The ideal femoral tunnel, the Canadian paper, which says that it should be isometric, direct fibers, anatomic, and low tension.
So basically, there is a debate regarding the ideal position of the tunnel. So we have come to a conclusion that it should be at the footprint of the ACL, wherein like it should be exactly between the anterior medial and the posterior lateral bundle, and it should be as flat as possible in the orientation, avoiding any acute turns. And this is what is the general consensus. But still the research is on. And
Yes, because there was one Scandinavian study in 2014, I think, which showed that the more anatomical the failure rates are more. I think it is because of the tension. So still we have, I think we need good randomized control trial or study between the ideal tunnel and your our isometric femoral tunnel.
yes,
Thank you, Dr. Pankaj. Excellent talk.
thank you.
Thank you, Pankaj. With this, I'll take the opportunity to introduce the next speaker, Colonel Rishikesh Pandey. He's heading the Department of Sports Medicine in the Armed Forces Medical College, and today he has a story to tell us about a fighter pilot. The fighter pilots or any of these elite professionals of military, for them, their professional work is very like all surgeons. We have to do a professional, otherwise, it's like a fish out of the pond. So if they are ever downgraded because of medical reason for anything, so they feel miserable, and he'll tell us a story about how he helped a person go back. And their medical standards are very high. They have to be in extremely good shape, otherwise there is no chances taken. So Rishikesh, over to you for the for your talk.
Thank you, sir, and happy Republic Day to all. Uh, I'll just share my presentation. Can everyone see it?
Uh, Not yet.
Okay.
Naresh, can you help him out?
Yes, sir.
Naresh is showing. So while he's sharing, I'll just say that Rishikesh is associated with the Army Sports Institute. The Sports Medicine Department of FMC kind of helps the Army Sports Institute, which is a very different type of organization. And a lot of athletes, I think Neeraj Chopra is the last which everybody would have heard of. But so many other who go for so many regional and local games and win a lot of medals for the country.
So, is it visible, sir, now?
Yeah,
Yes,
it's
sir.
good.
Yes.
Yeah.
Rishikesh, go ahead.
So, thank you so much for this opportunity, IS. So I have a story to tell, as sir said. This is about a pilot who was grounded after an ACL injury. and then we helped him go back to his flying. So, before I start, I'll give you a scenario. How many times, as surgeons, we have faced this scenario that we have done a perfectly executed ACL reconstruction, and the post-op recovery seems to be very good, and patient seems to be doing well. And when we follow up the patient after 6 months or a year or so, we find that the range of motion is full, clinically the strength is all okay, and no ACL laxity during follow-up. But however, the patient is unable to go back to his full functional level due to vague symptoms. So I'm sure all of us have faced this situation. And while you ponder on this question, I'll start my story. So this is about a 26-year-old male fighter pilot. He was actually a trainee pilot and chosen to be a fighter pilot, and he was training on an advanced jet trainer. Unfortunately, twisted his injury during a football match in February 2022. He was evaluated, and a perfect ACL reconstruction was done in one of our service hospitals in the same month using ipsilateral hamstring graft. Following which he was subjected to standard rehab and reviewed after a year, and clinically found to be fit and was declared fit to rejoin duty. However, there's one peculiarity of all these pilots. They have to also get a clearance from the aviation medicine specialist before they can fly, and they are sent to Bangalore for that. Now, all of you must be wondering what has flying got to do with ACL injury, because it's mostly a sitting job. But I should tell you that the requirements of fighter pilots are unique. They have to have a very good rudder pedal control, which requires full strength, and they are exposed to high G forces. They wear those suits, and they are supposed to contract their muscles and various do various maneuvers to keep their to while they are subjected to G forces. And another thing is they have to climb in the aircraft with a very on a very narrow ladder, where invariably the load comes on a single limb, and inside the cockpit is not a very comfortable position, and the pilot has to sit there in a cramped cockpit for a long time. So this boy was subjected to hop tests and was asked to run, and then he started experiencing pain. Hence, he was not cleared to fly and was asked to continue with rehab for another year or so. But the condition persists, and he was not again cleared to fly. So one of his seniors knew about us, so he kind of unofficially called us and asked us to help him. So he was transferred all the way from Hasimara to this place for us to kind of evaluate him and help him. So while when he came here, we found that clinically he was absolutely all right, well built young man, and surgical site was absolutely okay. The only finding we could find was a wasting of the cordyceps, which is again not a very unusual thing after ACL reconstruction. And clinically, the strength was all full, but that is the issue. Now we got a X-ray also done to see whether there is an obvious cause for pain or so. Found nothing. This was a well done ACL reconstruction, all inside. And we also got a MRI done to see the status of the graft and all. It was again, there was nothing, no significant abnormality was seen, and the graft was found to be intact. Then we proceeded to do a biomechanical assessment. So we did his strength assessment on a isokinetic dynamometer, which, for the information of all, has been supplied to all the command hospitals. So this equipment is available with all of us. I am not sure how many of us are actually using it. Then we also assessed his rate of force development and jump height using a single leg counter movement jump on a force platform. We also subjected him to single, triple, and crossover hops and a 6 meter timed hop. Additionally, we also did a gait analysis which showed poor dynamic alignment of his limb, left lower limb, and inadequate posterior kinetic chain activation of the operated limb while running. Psychological assessment was also done. Sometimes most of these patients are psychologically not ready to go back, but we found that there was no issue. So the verdict from our side was that it was because of poor limb strength symmetry, right versus the left, and inadequate neuromuscular control, and leading to inadequate load tolerance of the operated limb. So we kind of this was our target. This is what we generally use to kind of clear the sportsmen. The various parameters that we decide before we clear the sportsman to go back to a competitive level of sport. So we thought we should use the same for a fighter pilot, and sure enough, we started with a exercise prescription for him. I'll not go into details, but basically we concentrated on strengthening the limb because there was obvious asymmetry between right and left. Though clinically the grade was it was grade 5, but when you actually objectively test it, it was much less. And actually, you may lose about 30-40% of strength in the limb, but clinically you may still find that the power is grade 5. So that is why the importance of all these advanced equipment comes. So we kind of proceeded with advising him various strengthening exercises, stretching exercises, basic plyometric drills, and balance exercises, because all these parameters are important for a sportsman before they are cleared. So we thought we should do the same for a pilot. And he started the protocol, and we reviewed him after 2 months. We saw that there was improvement in functional performance tests and reduction in symptom provocation under load, and there was improvement in side to side asymmetry. However, it was still not what we wanted. It still did not reach those parameters. So we kind of advanced the rehab protocol, where we increased the load of his strength training and increased the complexity, and we started emphasizing on a unilateral strengthening rather than bilateral. And we use this repetition max as the load, and so we increased from more than 60%. So higher loads with transition from double limb to single limb strengthening, balance training advanced from eyes open static tasks on a stable surface to a dynamic eyes closed protocol on an uneven surface and perturbation based drills. And even the plyometrics were progressed from double leg pogos to a single leg plyometric drills. So he was assessed recently, 2-3 weeks back, and we this time found that he has reached that level where we could clear him for flying. So the good news is he was from here he was sent to IAM, and IAM has also now cleared him. So he can now expect to go back to flying and at least start training in his trainer aircraft and eventually maybe fly a fighter aircraft. So these are some of the photographs that we have, that how initially the knee contact angles which were stiff kind of improved, and hip knee extension and plantar flexion of the this thing of the lower limb, how it improved. And this basically suggests better engagement of the posterior kinetic chain, and which is important for efficient propulsion and energy utilization. And also frontal plane, this thing, better control and alignment, dynamic alignment of his lower limb. So basically his functional assessment, which initially there was a deficit of about 17% in single hop, has reduced to less than 0.5%. Triple hop, which was deficient on the left side by 16%, has now become equal, and crossover hop has also kind of improved. So this was the initial where he could cover only kind of 4.03 meters in triple hop. Now has increased to 5.88 meters, which is almost 20% improvement. Uh, Then a video of the crossover hop. You can see on the left side how at the end he's not able to maintain his balance, whereas on the right side he's able to kind of maintain his balance at the end of that hop. So this was his improvement. And then there are other things like Y balance test and a functional movement screen that we kind of did to assess his improvement, and he's basically regained his full function. So the point of discussion here is that a lot of times these patients come to us and we may think that there is some structural issue there, but the problem is that cause of that persistent pain may not be because of some structural issue in the graft or some other issue in the knee, but it is basically because of load intolerance because of asymmetry, and graft failure is not the real cause for there. And in this case, marked quadriceps and hamstring asymmetry was likely the key limiting factor. And his functional recovery was lagging behind the surgical healing. And as we kind of subjected him to various rehab protocol, we saw that the objective symmetry correlated with the symptom resolution. Now, as surgeons, what is there for us to learn? That clearance based on just time of, let's say, 1 year from the surgery, or restoration of full range of motion, or no laxity in the knee, or for that matter, even clinical strength testing of grade 5 is not sufficient in such high demand individuals. We most often assume that the strength is symmetric, and we generally do not actually measure it. And since we now have the wherewithal to do it, I think we should use that. And higher demand occupations basically need higher threshold. So you can't just do some cursory clinical examination and decide that the patient is fit. And definitely rehab quality determines surgical success. Just doing a good ACL reconstruction is most often not enough. So various goals of rehab is not just restore range of motion or laxity in the knee, but also regain full strength, reestablish full proprioception and neuromuscular control of the knee. You should be able to restore the speed, explosive power, and agility. Core stability is important, and last but not the least, psychological readiness. So only range of motion or no laxity in the knee is not enough. So to conclude, ensuring full functional rehabilitation is a teamwork, and awareness amongst the surgeon about various modalities how to rehabilitate is equally important, as important as knowing how to do a ACL reconstruction. Because in our setup, the surgeon has to be boss, and we just can't leave the patient to a physiotherapist who will decide what to do. And then reassessment also, the surgeon should be actively involved. So that's all from my side. Thank you.
Thank you, Rishikesh. As always, an excellent presentation. And I can say that what you really brought out is that just doing surgery and the wound healing, and he starts walking without a brace and a walking stick is just not enough. But I'm not sure how many of us will have access to this kind of a privilege of following up the patient, doing so much for the patient. But yes, everybody can try, or at least recognize who need this and then try for them. That will I think the post rehab is the most important. Rehab is also important. Thank you so much, Rishikesh. It was excellent. I learned a lot, and I know how to look after to look at my patients now. Just doing surgery is not good, even if the patient is very happy. Any questions from the audience?
There are no questions on YouTube. However, I would like to ask one question that
Yes.
what is the graph choice for the army personnel, and does it differ according to the levels of the personnel?
Graph choice in most situations is hamstrings only, ma'am. But nowadays, peroneus longus is also being increasingly used. And I personally I use BTV graft when there's a failure of a hamstring graft most of the times. So this is my personal choice, and I think this is generally what everyone follows in the army.
Yeah, so I can say that in Peroneus longus, there was initial apprehension. This was about 4 years back. In FMC, we did two studies. One about the strength, about the after the Peroneus longus. One was about the Peroneus longus usage, and once if there is any strength loss, there was actually no strength loss. These was actually the two thesis topics done by my students, and there was just no strength loss at all. So it is a good choice for athletes and soldiers now. It is routinely done also. And now I think it's pretty well established.
I
Thank
have
you.
a small question, sir, if I may be permitted.
Yeah, Akshay.
Sir, I'm Lieutenant Pushkar, sir. Sir, with such excellent rehab that Rishikesh sir has just mentioned, do you think there's a role of non-operative treatment with this such nice rehab and prehab and post rehab?
So I'll take that question. Yeah, actually, frankly speaking, you must be aware, even elite football players, FIFA, and I mean, playing Premier League and all, lot of them have ACL injuries, and not all of them actually get operated. And some of them actually go back to playing their professional football. But then that again, it's not a blanket thing that everyone will kind of will require or will not require. There is a role of prehab which I have not talked in this talk, but the ideal scenario is after the injury you subject the patient to a prehab where similar exercises and all have to be done, and then reassess. Person who does not have instability, clinical, I mean, symptomatic instability, maybe you can manage them without surgery. But someone who persists with instability even after prehab definitely requires a surgery.
That
Sure.
opens a gamut of questions, sir, like when should be the duration of how much prehab should be done, when to go in for surgery, because delay in surgery also leads to its own issues, the
Yeah,
cartilage
so
damage and all
prehab
those.
has
Like,
to start actually immediately. I mean, you shouldn't wait for the swelling to kind of come down and I mean,
I
okay,
mean, when to wait for surgery? How much time should we wait for surgery?
6 to 8 weeks at least of prehab is required, minimum.
Sir,
Yeah, I
thank you,
can
sir.
say like even before Rishikesh came to the department, I can say my own experience that Army Institute of Sports and the Sports Medicine department there were helping us in doing a prehab program. I think Rishikesh, you also started doing that. This we could afford to do it because we in the military they can be continue with the job while they are. I mean, they can be left out of the job while they can do this job. They can be in the hospital also as just doing rehabilitation under direct observation. So that's an advantage of military. So we had a program like that when we kept some beds in the ALC for prehab, did some cases and then post-app, and I can tell you that a lot of results they presented that in the national conference also the last time. Many of these guys did so well, and they went back to sports very quickly. I think within 1 year they went back. Two cases, I think one in fencing and one in yachting. They won the medals also. Within 1 year, they went back to sports. Okay, so that's the power of rehab.
Yes, I think that is important. How you are training your hamstring and quadriceps, and I think if they fire well, I think most of these patients does well in the course of time.
Right. Next speaker we have is
Dr. Rupesh. So we've
Kalmanish will
uh,
introduce.
so we have covered three topics as far as knee is concerned. Now coming to the second most common injury in FMS, that is shoulder instability. So we all know the young soldiers possess significant challenge due to its physical demand and identifying instability. Pattern helps in optimizing surgical planning as well as rehabilitation process. So Dr. Rupesh is going to talk about shoulder instability pattern in a young serving soldier. He has worked in a tertiary care center and he's going to share his experience over there. Dr. Rupesh, please.
Thank you, sir. Good evening to all of you. Today, I'm going to share my experience of last 1 year at Command Hospital Chandi Mandir. The shoulder instability patterns which we have observed in the young serving soldier, and they are unique in terms of biomechanical demands, high physical exposure, and distinct injury pattern. So I have nothing to declare pertaining to this presentation. And if we see the relevance of this talk, shoulder instability in soldiers is clinically important because of because of deployment in varied terrain, intense physical training, driving and operating military vehicles, and participating in competitive and contact sports. And this leads to repetitive and high energy loads on the shoulder, often leading to recurrent instability at a very young age, with significant implication on operational readiness. So I will be discussing 4 different kind of cases which will describe the spectrum which we receive here at Command Hospital. The first case is a functional instability which will define that not all instability require surgery. So this is a 33-year-old serving soldier presented to us with pain and weakness of shoulder, apprehension and load shift positive, with no significant finding on radiological and MRI, which explained that there was functional instability rather than the structural pathology. So we managed with the physiotherapy protocol by Watson regime, first making the scapular motor control more robust, then the posterior muscle development, flexion control, high range scapular or humeral control, deltoid strengthening, and sports specific functional training, and patient improved. Second case is a 25-year-old serving soldier with presented with pain and instability left shoulder with 4 episodes of anterior dislocation, apprehension and load shift positive, with anterior labrum periosteal sleeve avulsion, with glenoid track of 24.4 and Hill-Sachs of 29 which made it engaging lesion with glenoid bone loss of 8.9%. And we managed with arthroscopic Bankert repair and remplissage. Third case is a 28-year-old serving soldier presenting with numerous episodes of dislocation, and it dislocated even in the sleep. Again, apprehension and load shift test positive. MRI showed anterior labral periosteal sleeve avulsion, and it was non-engaging lesion with glenoid track of 24.5 and Hill-Sachs defect of 15.7 and glenoid bone loss of 18%. So we managed this with open Latarjet procedure. We as a protocol have very low threshold for open Bankert, open Latarjet procedure. We take it glenoid loss of 13.5%. Less than that, we go with the arthroscopic procedure. So this is the post-op X-ray for the same. And the fourth case is 27-year-old serving soldier presented acutely with pain and swelling left shoulder with fracture antero-inferior glenoid. And this is the CT scan of the same patient. And we fixed it with arthroscopic repair. So in the fourth case, when it gets neglected, it leads to devascularization of the glenoid fragments, and that leads to glenoid bone loss. and that in turn later leads to instability symptoms. So when we go to the shoulder instability classification, it can be based on the direction of stability, anterior, posterior, inferior, or multidirectional, or based on etiology, traumatic or atraumatic. And there are many factors which affect the shoulder instability: age of presentation, hyperlaxity, glenoid bone loss, engaging or non-engaging, whether the patient is in contact sports or not, and serving soldier present with multiple factors at the same time. So the decision making whether to go for the conservative or non-conservative we have to consider the multiple factors. And conservative for conservative we follow Watson regime at our hospital. And for the surgical procedure, we consider age, hyperlaxity, glenoid bone loss, engaging or non-engaging lesion, or participation in the contact sports as a decision making for the surgery, which and type of surgery. And as I earlier told, that 13.5% glenoid bone loss is our cutoff for arthroscopic oblique open Latarjet procedure. So when we analyzed our cases for last 1 year, we found that the average age of serving soldier varied from 19 to 46 years, with the average age of 26 years. And the glenoid loss, bone loss varied from 5 to 32%. And the injury pattern which we saw, we found that the bony Bankert lesion was 30, which was very significant out of 48 patients. And they all presented very late, and ALPSA, anterior labrum periosteal sleeve avulsion, was in 14 cases, and we found one Perthes lesion on MRI. So we, out of 48 cases, we did open Latarjet procedure in 30 patients, and 18 we did arthroscopic procedure. And in the follow-up, we found that up to 1 year follow-up, there was 0% dislocation rate in our patient with that protocol. So when we found out the military papers pertaining to other countries in the world, we found that there was 34% recurrence rate, and it was more in the post arthroscopic procedure rather than the open Latarjet procedure. And not all shoulder instability, even 60% of the shoulder instability were pertaining to posterior, either posterior or multidirectional. But if I summarize what was finding in our soldiers, it was mostly traumatic, and multidirectional instability is not very uncommon. So we cannot neglect multidirectional instability. We have to evaluate in our OPDs, and since they present very late, we find that the ALPSA lesion were very common on the MRI, and glenoid loss more than 13.5% was very it was in the most of the cases. And since we have found early traumatic glenoid fractures, so early recognition of glenoid fractures and their fixation can prevent devascularization of glenoid, and which can prevent chronic instability in the soldiers. So this was one of the patient which he was not operated here. This case was done at MH Jodhpur, and he sent us the WhatsApp video. So I have uploaded on this to show that after good arthroscopic procedure, person can return to his military on combat duty, and he can engage in sports. And this This is the second video which he has sent for the vertical rope. So choosing the correct procedure in a highly demanding patient can give you good result, and they can return to their military duties. So thank you so much. So we have to give them individualized treatment, and we have to keep open lethargy procedure threshold very low, which generally people keep it 20 to 25% bone loss.
Yeah, thank you, Rupesh. I think you brought out some very good aspects about the injury. So, with my, I did about 30 years in the service and about 24, 26 or 27 of them in orthopedics. So, I can tell you a few things about what I learned about shoulder, because shoulder arthroscopy started much later in our country and then much later in the armed forces, also about 2, 3 years later than that. And I found that firstly, all of them, there is a tendency even now, because these injuries are very common during sports. You know, they do a lot of sports. They have during they have the sports or during firing, and they are normally reduced and without anesthesia by the local ustad there or his companion. No? Because many times the orthopedic surgeon or even a general surgeon is not available where this dislocation happens, and he immediately goes back sore for a few days, then he's all right. And so they don't seek treatment. They think, and he's given some rest for by the unit also, and they feel all right till he dislocates second time, and then he keeps dislocating, and every time he does that. So I'm just giving this context in relation to a study by the American Army, again the American thing, in which right now I don't know what standard you follow, but we were always looking at 3 dislocations before we went in for surgery. And as of now, we have MRI and all that. Earlier on, we were looking at this standard, but now we take an MRI and then decide surgery required or not, right? So I'm talking about 10 years back when the Americans published this study where they operated even a single dislocation they operated. And they brought down the re-dislocation rate and the poor rehab rate and return to function to very close to less than 5%. So I don't know what Manish or Dr. Rajiv or anybody else like to add anything in their experience about how do they handle such cases?
I agree
Sportsmen
with
or
you, sir.
athletes. Should you take the first dislocation as going in for intervention, or you should
I
get an
think,
MRI and then go by the usual standards of?
Depends on the age.
yeah, so again, if you see the recent instability scoring, where age is a very important criteria. Younger the patient, chances of dislocation is high. So young patient, I think soldiers are like elite athlete. I think you should go for surgery. Yeah, if he is active soldier, I think this will reduce the risk of dislocation in due course of time. And I think that has been proven by all the Pascal Bolle study also.
Yeah.
So nowadays, younger the patient, first time dislocator, I think we are now more aggressive for surgical options. Definitely, but we were students also. That was the standard teaching that more than 2 times is recurrent, and those are the classical patients for surgical option. Otherwise, rehab them. But I think with recent studies coming on about the instability scoring, so now we score this patient, and if they
More
score
and more.
high, I think better to go for surgery to reduce the risk of dislocation.
It's very pertinent in our case, but at times I find they go for some another second opinion in another hospital, and they're usually advised no need for surgery, go for it after that. That's why there's a little conflict. Though we want to do, and that's all. Right. I think any other points from anybody or any questions?
Neha, you are muted. Yes.
Yes, sir. So there are no questions on YouTube. However, I just wanted to just add up to that thing that if the person, the patient is less than 22 years old, then and conservatively managed in after first dislocation, the chances of dislocation are around 72 to 75%, which are very high. So as Rajiv sir also said, it's better to operate him early rather than
Early is better.
waiting for the second dislocation to happen. Thank you, sir.
If we have time, can I add a point?
Yeah, Akshay.
So one unique problem for armed forces is like boarding out of young recruits and cadets. So that I think it's not relevant to the civil setup, but yes, if the patient undergoes surgery at a young age, especially cadets and recruits, they tend to be ported out. But if we give them maybe 3 months of temporary rehab and some temporary shelter, so they may be retained. So that is another aspect to be considered before going in for surgery.
And this is an absolutely
But
different
yes,
thing. It's about recruitment and the fitness for service. So that's a military debate we can do some other time.
Yeah.
that's right, sir. So
I think Manish, last speaker.
Yes, sir. So the last speaker for the day is Dr. Arvind. He's going to talk about reliability of CT for calculation shoulder instability. So over to Dr. Arvind.
Last but not the least, and the youngest member of the team.
Yes, and sir, he is finishing his study leave this month, sir, and he will be joining Military Hospital Jalandhar, sir,
All right. Okay.
under Dr. Ayappan Nair, sir.
Yes, yes.
Okay.
I
Right.
met
Yeah,
him
you are doing in the Scopy.
process.
So he's the budding Scopy surgeon of the army.
Thank you very much for the kind words, sir, and happy Republic Day to all the seniors. Let me just share my screen, sir. Okay.
Arvind, there is some issue. Can we help you?
Yes, sir. I'm just trying to
Yes. First,
share my
open
screen, sir.
first open your PowerPoint, and I think then click over the share screen.
Yes, sir. Is it visible, sir?
No.
Not yet. You just shared it earlier, right?
Yes, sir. I have shared it earlier.
Well, I hope so, but nobody else is sharing. If somebody is
No.
sharing, you should.
If someone is sharing, it should come over the screen. So what you can do, Arvind, have you opened the PowerPoint? First open it.
Yes, sir.
And
It's open, sir.
then minimize, and then you are
Minimize
back
it.
to Zoom.
Give me 1 second, sir.
You are joining by mobile or laptop?
Okay, I had joined by both, sir. I had just switched off my laptop.
Yeah. It's better if you share by laptop.
Yes, sir.
Sometimes mobile, it's very difficult to see all those tabs.
Yes.
In the meantime, there's one question for Dr. Rupesh. So one of your cases, the glenoid bone loss was 32%. So how do you manage the bone defect? Because sometimes the coracoid graft is not enough to compensate for that defect.
Yes, sir. So I have limited experience, sir, because we generally use coracoid graft. I got away with that case with coracoid graft, but I'm going to Ayappan Nair, sir, to learn some more techniques on this.
So
I have no
more than
experience with
30%.
some other graft here, sir.
I think iliac crest bone graft is a good option for more than 30% bone loss because that will cover your glenoid tract.
Yeah. but I don't have any experience with that, sir.
We have modified our practice a bit, sir. Now
Yes.
we have, in addition to the normal lethargy, we are also putting an anchor, and we are trying to do the inferior capsular shift along with
Yes.
the lethargy. So this has given us a better result as compared to our previous
I
technique.
think this is one of the important thing. If you can shift the IGA in anterior band of the inferior glenohumeral ligament, I think that is one of the important dynamic stabilizer of the shoulder joint, and that significantly reduce the dislocation rate.
Dislocation rates.
Naresh, can you call Dr.
Sir, he is not responding to my call, sir.
Dr. Arvind? You can talk with Dr. Naresh. I think he will help you.
I'll just open my listening in my laptop.
Yeah, laptop. It's better to present by laptop because you can see all the tabs. Any more question, Naresh, Neha? On the
So,
No, sir.
can I ask one question?
yes, yes.
If the glenoid bone loss is more than like it's if it is it's a scenario. So if it's 15% plus the heel sacs is off track. So how would you go ahead, if I may ask all the faculties, starting from Sood sir?
You are muted. Dr. Sood, you are muted. Unmute, yes, please. Yes, yes, yes.
Okay, so I'm sorry I didn't listen to the question. Can you just repeat? I'm really sorry.
I just wanted to ask a scenario where the glenoid bone loss is like 15%, more than 13.5,
Hmm.
but it's 15%, and the heel sacs is off track. So it's a big heel sacs which is engaging. So how would you go about in such cases?
Yeah, in such cases, see, I have limited experience in shoulder scopy. Since I shifted more toward arthroplasty, but in my times we were mainly doing a remplissage procedure and seeing if it solved the situation, then we left it like that. I did not kind of augment it with a bone thing.
we in that case, sir, we have to consider multiple factors, sir. First is the first is how many episodes of
Yes,
dislocation was there. The secondly it is engaging the bone loss, and how what is the profession occupation of the patient.
yes, yes.
So based on that, we can decide which procedure is better for them. So in this case, if a sports person is there with 15% bone loss and it is engaging, I would go for lethargy.
So I think there's this there. I think Neha was asking if it is subcritical and critical. So if it is a critical bone loss, I think lethargy is the option. If it is a subcritical, I think less than 10% of bone loss with a large heel sac. The another procedure, Bankart plus now we add is a dash procedure, rerouting the biceps to the subscapularis, and that has also significantly reduced the dislocation rate. Now, Arvind, I think we can see your presentation. Can you say it in the
Yes, sir.
presentation? Yeah.
Yes, sir. Thank you very much. Thank you very much, sir, and for the delay. So, taking forward some of the concepts that Colonel Rupesh sir was saying regarding the cutoff for the CT base or the bone loss for which we decide on to go ahead with a bony procedure or a Bankart. Similarly, an interesting thing that we wanted to know is how reliable are these studies after all? Because we are basically at the end of the day choosing the kind of surgery based on these patients that the judges give us with. So for this study, so our basic aim for this study was to basically to compare the accuracy, precision, and inter-observer variability various standardized CT-based bone loss calculation in patients with shoulder dislocation. So, with the literature, we were able to find out that even an systematic review as recent as 2023, they have not come up with any particular method which they state as
Arvind, we
absolutely
are not
accurate.
able to see
They
your
say that
slides.
Just move your slide
sorry.
and play it in the presentation mode. I think the presentation mode. Write down, I think this square you
Actually,
can
it is in
click.
the presentation also.
Right.
Slideshow mode. You start slideshow. Up you have option of slideshow. You can start slideshow.
Yes, sir.
Just click.
Arvind,
Yes, sir.
close your video and you can speak. That will increase your internet speed. You can
Okay, sir.
shut off your video.
Yeah. Start slideshow. I think you have options there in up also, and I think you have unshared your screen, Arvind, here. Now it's shared. Yeah. Start presentation mode, slideshow.
Yes, sir.
Perfect. Yes.
Yes, yes, sir. So, sir, am I audible?
Yes, you're
Yes, you are
audible.
audible clearly. Yes.
Yes. So thank you, sir. Given the reason that systematic review showed no one particular method to be absolutely accurate, and clinicians to be aware of the limitations by choosing the technique. And even some other studies show that it is moving, sir.
Yes, Arvind, it is moving. Yes.
Uh, Even some studies show that, in latest studies like 2024 JSS paper, show that beyond guesswork, how our surgeons treatment, they show that even though there is a lot of interval able pretty low in many of the techniques, but the reliability, actual bone loss calculation might vary from the actual bone loss defective. So what we did was, and top of that, is a factor that that the critical bone loss has been redefined over the past years. Such as Shiva 2015 by job in they found
I think there is an internet issue with Arvind. I think some internet issue is there. Arvind?
Sorry, he has got internet issue, so he is completely disconnected, sir. He is again trying to connect.
So we
All
can
right.
just wait for a minute and see, because I
Yes,
think
sir. Yes, sir. Yes, sir.
Rupesh, you can try and call him and find out. He needs help.
We can take a few questions if there are any.
I think he's sharing. Yes.
with this background. Sir, am I audible?
Yeah, you are audible and your screen is visible also. Yes. Presentation visible. Perfect.
Thanks. So with this in mind, the lab study basically decided to make some bone loss on the 2D as well as 3D in-phase views of the normal brain, which was achieved from the fact system for tertiary hospital. And these which not use facts the radiology the precise bones that we so we took around the actual inferior border of end-phase view of the human. So I think I'll show this.
Arvind, I think your presentation is not.
Yeah,
I can't see your presentation. Yeah. And again, oh, there is
I
network
don't
issue.
think, it's not really happening.
Hmm.
So he's out of, again, he's disconnected, right?
Yeah.
I'll just try to call him.
I think he's not picking up the phone also, sir. Maybe the internet issue is there, sir.
Yeah, there's a big issue. I think we'll try to call him conventionally. You know.
I think there is some network issue.
Yeah, major issues there. It was all okay until some time back.
We have already extended the time, sir. Is there any time constraint?
No, there is no time constraint, I think.
We
Yes.
just wait for 2 minutes because he's made a presentation.
Yes.
Yeah.
अरविंद थोड़ा ना नेटवर्क इशू आ रहा है आपका. हाँ,
हेलो सर
मैंने कहा नेटवर्क इशू आ रहा है, इसको थोड़ा यू कैन मूव आउट समवेयर. थोड़ा बाहर मूव करके देखो कहीं पे. है, वी आर वेटिंग फॉर यू. ओके, आई जस्ट टोल्ड हिम to move a location and specify not.
I think just a small question, because all of you are treating a lot of soldiers. So most of these injuries are during practice or when they are in war zone, or when they are in real time working in different difficult terrain like mountain and all those things. So what are the commonest mode of injury?
So the commonest was that brought out by one of the speakers was during sports. Because sports are played every day. They have a morning exercise, and in the evening, sports is compulsory for everybody. So they have to field mainly field games, sports, and training injuries are very common. During training, they have their entire backpacks, rifles, and performance is also timed. So training is also one of the time when maximum actual combat may the injury pattern is different, and these are very minimal issues then. That's not the real thing, and then the conflict is very. So in you see most of them are deployed at very arduous kind of terrains and very different type of atmospheres. So and for months there is no, like, in those hilly areas, swamps. So there's no actually exercise. You are under a lot of fire, so you can't do exercise also. So you are actually huddled, and then you have to go back, pick up heavy stuff, and bring back, whether it's ammunition, food, water, for all the posts which are man maintained. So in these places, I found that maximum time they twist the knee, and they are not in a position to take the treatment. Also, by the way, they cannot be evacuated. So many times they'll be coming. Finally, when the unit is going out from an operational area back to a peace area, and they have access to an orthopedic surgeon. So that's also a tragedy, actually. That's the thing. Arvind is back. Arvind, let's see.
Arvind, welcome back.
Sir, am I audible?
Yeah.
You're audible.
Thank you, sir. To can uh, uh, also made on the view. We made sure that we are selecting the standard in-phase view, because in-phase selection itself is a very complex. A recent paper by Moroder et al. Showed that there is only 30% correlation with or agreement between on what actually would be for them, that for them. We save these virtual bone losses on the backs, and they have given muscular to on space population. So the and the actual methods been radio space loss. And we did the analysis, we did a correlation coefficient, the inter-observer, and we found that the maximum with respect to the accuracy as well as the variability, especially they should again, but the actual the trueness of this particular value using this technique when compared to the original was very different. So this shows a kind of a systematic overestimation wherein the radiologists are agreeing to their value, but the actual value lies way far away from the actual bone loss. So based on this, we found that the Sugaya method using
I think he's hello. I think he's again off, right, Naresh?
Yeah, I
Yes,
think
sir. Yes, sir.
So maybe
poor network
probably
area.
should
Sometime in
abort
hospital, the
abort.
network is not good here.
Yeah, because even when he connected for a short while, it was not very clear.
The sound actually that suggests that I think he is inside the theater or something inside the hospital. Sometimes the network is not good.
Yeah.
So,
So should we like wait, or should we? I don't think he's. I talked to him. He changed his position a bit, but I don't think he's come getting it
I
right.
think the network issue is there, perfect. Rupesh is trying. I think last we can try and then again.
Rupesh, why don't you ask him to connect to the mobile hotspot or something
Yeah.
if he doesn't have Wi-Fi, or move out?
Sir, he has difficulty in connecting, sir.
Oh,
So
all right then.
So we can, I think, some other time.
yeah.
Right. Uh, okay, Dr. Rajiv, if you permit, then we
Yes,
can
yes,
end the
sure, sir.
session. Okay. All right. Firstly, I'll again thank the organizers on the occasion of the 77th Republic Day. The opportunity was given to all of us to present our work, and I'm sure there are a lot of take-home points. At least I learned a lot, and the scenario may be different, but the conditions are the same, and some of the things can be applied in many other settings also. And without I don't know, and I think it may be a good idea as a follow-up of this thing. If we can put in some recommend, especially I'll request Rishikesh, if you have the protocol, if you can send it across, then we can probably give it around for people who can use it through the IES forum also. You know,
Sure, sir.
Yes.
the post-hub protocol. Rest, if there are no questions, Neha, and anything from Manish and Dr. Rajiv, if you would like to close.
Yeah. Thank you so much, and thank you, Defense Week, for wonderful webinar. Yes, Neha, Naresh.
Yes, sir.
Right. If
I
not, then
think
I thank again Dr. Rajiv, Naresh, and Nehat for enabling the whole process, and Rupesh to sewing it together to happen. And I think we should do a more. I think we should aim for at least one in a quarter, if not more. You know. So
yeah,
we'll
we will
come
do
back
that.
with the program. I think we are doing it for the IOCON also and for you also. So the
Yes.
similar thing we are going to do that for them. Right? Okay. Thank you
Yes,
so
sir.
much for the opportunity. Thank you, Naresh.
Thank you.
Thank you, sir.
All right. Thank you.
So
Thank
can
you.
you,
And happy
everyone can,
Republic Day to
Thank
everyone.
you,
yeah,
sir.
open
Thank you,
the
sir.
camera so that we will take a screenshot, small screenshot. Akshay, Shivendra, you can open the video. Yes, Manish, Gokul, Sumit is there.
Who are running? Gokul, Sumit. Yeah, yeah. Akshay looks like he's in a bunker.
Yeah. So I think finally we should stand up for national anthem on the
Right.
yeah. Naresh, you are sharing?
Yes, sir. Yes, sir.
Naresh, audio is not there. Please. Ganesh, audio is not there. I think stop sharing. We can do ourselves. Yes. जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब
पंजाब
सिंध सिंध गुजरात मराठा द्राविड़ उत्कल
हिमाचल यमुना गंगा उज्जल
जल
निरंतर
जब
शुभ नामे जागे शुभ नामे
गाए तब गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय जय
जय हिंद
जय हिंद। जय हिंद सर।
जय हिंद
Okay. Thank you very much.
थैंक यू
Yes, sir.
Thank you, sir.